So if you would like to share this recording with anybody else on your team or any of your physicians, feel free to do that. Just let us know and we'll send you the link for it as well. So here's what I want to accomplish over the next 30, 40 minutes. I think we'll probably be able to finish early. Is I'm going to start and show you, here's the demo. Here is the brief overview of the work that White Plume and SRS have done to allow for a tighter integration between our two applications. SRS published these APIs. We work with them to integrate so that we can populate the diagnosis data and the visit type data back into the EHR out of ExcellaCapture. I'm going to show you how that works. And then I want to spend a little bit of time explaining why we think that's so important. As we make the change from volume-based reimbursement to the value-based world, better data is really important, right? We have to be able to show and have the information to know how well our patients should be doing. How sick are my patients compared to my peers? That's essential. And some of this data now is patient-facing, where Medicare is publishing information on cost, publishing data on quality, right, where patients are going to have access to that information. You're seeing them have access to that data through the portal. And that's why we think it's important to have better data and be able to capture that. But we also want to be able to do that faster than you do today. It's really important that we don't turn our doctors into data entry machines. That's not good for our doctors. That's not good for our patients. So we want to be able to capture better data faster than today. That means fewer clicks. That means capturing the data one time and having that be automatically sent both to SRS and to your practice management system so that the claim can be paid. And I'm going to show you how to do that. And then I'm going to go back through and come back to the demo again. And this time I'm going to slow down a bit and not show you the fast demo. I'm going to show you a slower demo that walks you through the steps a bit more, that shows you how you can capture better data, how some of our clients are leveraging ExcellaCapture to do that, right? And so if you've got questions after that first demo, send them into Shelley, and we'll try to clear those up in the second time around, okay? Again, I'll make sure that I leave time for questions and answers at the end. So feel free to use that questions panel for questions that you have. Feel free to use that for any follow-up information that you'd like. I think that's a helpful way to communicate with us during the webinar. At the end, we have a very short 3-question survey that lets me know how we did on our webinar today. I look at all those responses. It takes 30 seconds. It's extremely helpful for me. So if you don't mind, I would greatly appreciate it if you'd take the time to quickly fill out that survey at the end. All right? So thank you again for joining us this morning. And what I want to start is showing you the work that's been put in to make this integration possible. So here's what the workflow looks like. When I capture data on the electronic superbill in ExcellaCapture, right, it's going to route that data to 2 places. Number one, it's going to send that information back into SRS to populate the diagnosis app, to populate the visit type app with that data. Now it's also going to send that to ExcellaSmart, right? That allows me to not turn my doctors into coders, to allow me to leverage some of the post-encounter coding that's in ExcellaSmart so that I can have better revenue cycle outcomes and ultimately send that transaction onto my practice management system so it can go out the door, right? So what we've added with the API integration is the top part. The API allows that to happen in real time. So as soon as I save the encounter in ExcellaCapture, it updates that information into SRS, right? So that information is there, eliminating the need to duplicate that data entry. So let me show you how that works, because I think a picture is worth 1,000 words here. So what I'm going to do is I'm going to come over and log in here to SRS, right? I've got my patient, Emily Plume. Many of you use the Power tab in SRS to launch that patient encounter, right? Some of you don't do that. Some of you use the appointment view. Either way is fine. Either way works just fine with the API. But what I'm going to show you is if I launch on the Power tab and click on Emily Plume, what that does is it launches that patient's electronic superbill. So it preserves the patient context. I don't have to log in again. I don't have to pick the patient again. And now I've got her electronic superbill up. If I've got a level 3 office visit for an established patient, I can click that. You'll see it highlight yellow, just like you do today. I flip over to the back side where I've got my diagnosis codes, and maybe I've got bilateral osteoarthritis of the knee. She also mentioned some lower back pain. So click, click, and I'm done. When I'm finished, all I need to do is click on complete, or I could click save if I wasn't finished, and complete will close the electronic superbill, save the encounter data, and send it to SRS. So when I come back into SRS and I click refresh, what you'll see is there's that bilateral osteoarthritis of the knee with the diagnosis code, today's date, the lower back pain, today's date. It's got the visit type information, right, with today's date on it. I've got all of that data pulling straight in from Capture into SRS, so I don't have to enter that data twice, right? The thing that I love about this is how simple it is to show people how that works. It's really, really easy. There's a lot of hard work that went into that for SRS exposing these API calls. Their developers working back and forth with our developers to be able to make sure that the calls worked correctly, the calls worked very, very quickly, right? But I'm really excited to show that to you because I think it helps you capture better data to have in your EHR, in your patient portal, for your analytics. If you want to do population health, all of that is really important. We're able to capture better data and do it with fewer clicks because I can do it in just one spot, right? And we think that's really, really cool. So I wanted to walk through and show you that at the very beginning as to how that works, what that looks like. Capture the data in Capture. It gets routed to both SRS and to Smart, so the clinical and financial data is captured in one place. All right. Now, I do want to talk a little bit about why we have done this, why we think it's so important, where we're headed, right? What's the need for better data, right? You hear a lot about MACRA and MIPS and where we're headed with value-based reimbursement. The 50,000-foot view of what the government is trying to do is accomplish the triple aim in healthcare. Right? Medicare is unsustainable as it is today. We have 10,000 baby boomers every day aging into Medicare. And to accomplish the triple aim of better care with lower cost and an improved patient experience, Medicare cannot do that alone. They've got to involve patients and they have to involve providers. And to do that, what they're doing is shifting risk. They're shifting risk to patients. They're shifting risk to providers. Right? On the patient side, you've probably seen this in your own health plans where for the past couple of years, and we expect this trend to continue, there are higher premiums, higher deductibles, right? That involves patients in the economic impact of their healthcare choices, assuming that they will better allocate resources if it's some of their own resources, right? You see that happening. The other part that you see is the emphasis on patient engagement, right? This is what Patient Portal is about. This is what VDT is all about, is getting patients engaged, sharing the data with them, right? So patients are getting access to some of this data. Now you're also seeing on the provider side, right, you're seeing where the providers are having some of the risk pushed onto them as well. This is happening through QPP, this is happening through ACOs, through APMs, through the MIPS program, where Medicare is trying to measure and pay for quality, measure and pay for outcomes, measure and pay for cost effectiveness. That's the big picture category of where we're headed, and Medicare has a timeline for this. When you look at the way that they classify their payment structure, they have 4 different categories. Category 1 is the old fee-for-service. This is what's been in place since 1965, where you get paid for CPT codes and that's it. Most practices today are in Category 2 payment categories, which means it's linked to quality, like PQRF, the value-based modifier, the quality category under MIPS are all in that Category 2 space. And CMS is trying to move people towards Category 3 and Category 4. You look at where that payment distribution is today, 55%, the majority are in Category 2. They expect the majority to shift to Category 3 and Category 4 over the next 2 years. So we have some big changes ahead, and if the government is trying to pay for quality and pay for cost, you need to be paying attention to that. That requires you to have some of that data and to be thinking about that, right? They're publishing some of this data as well. I don't know how many of you have looked at your QRUR report. This is about the old value-based modifier program that was sunset with MACRA, but that comes right back in the cost and quality categories under MIPS, where the two big focus items that Medicare has been interested in for years are cost and quality, measuring cost and quality against your peers, right? That was true under value-based modifier. You see that in the MIPS category as well, meaning cost and quality are always equal to 60% of your MIPS score, right? So the majority of your MIPS score will come from those two factors. That's what they care about. Okay, so the reason I point that out to you is it sounds very simple that Medicare wants to start paying for cost, paying for quality, and measuring that. The pushback from the provider community has always been, wait a minute, you don't understand. You can't measure quality. You can't measure cost because my patients are sicker than the average patient, right? If my patients are sicker, they're going to have worse outcomes. They're going to have higher costs. Right? Medicare is saying, okay, we get that, and we're going to take that into consideration, but you have to prove it. And the way that you prove that is with your data. Right? So let me give you an example that I think is helpful. Let's pretend that we have 3 identical patients, and they are much sicker than the average patient. Right? They all need total knee replacements. And so what we're going to do is we're going to do that procedure. We're going to get paid for the 27447. And under the fee-for-service regime, you have to have a diagnosis that makes it medically necessary, right? So in patient number 1, we code unspecified osteoarthritis of an unspecified knee, right? Remember, we had that Medicare grace period where they weren't going to deny claims for lack of specificity, and they haven't really brought the hammer down on that yet. So that patient, to the payer, whether it's Medicare or one of the commercial payers, looks relatively healthy because all we've coded is unspecified osteoarthritis of an unspecified knee. Patient number 2, we are more specific on the primary diagnosis, right, to make sure that we don't get that claim denied as Medicare and the other commercial payers start to require greater specificity under fee-for-service. But we also code morbidly obese. The patient has a BMI greater than 40. Well, that certainly has an impact on how they're going to do post-op, how they're going to recover, and it makes that patient look sicker, look more acute to the payer, because this is the data that they are using. Payers are using claims data to measure patient acuity. The methodology for that is HCC, hierarchical condition categories, that takes into effect the patient's demographics and the patient's diagnoses. I don't have time to go through the lengthy explanation of HCC coding today, but I will reference you a separate webinar that we have that's very helpful that goes into the details of that. If you've got questions on that, if you need more information, let Shelly know through the questions panel. We'll get that to you. So patient number 2 looks much sicker to the payer than patient number 1, even though they are identical patients. Now the third patient, not only do they have the osteoarthritis of the knee and morbid obesity, but they also have type 2 diabetes with a complication of polyneuropathy. Right now we have fully painted a picture of what that patient looks like, and that patient looks much sicker to the payer. In fact, their HCC score is over twice that of patient 1. And CMS is using HCC for risk adjustment under the cost measures in MIPS. They use it for risk adjustment under the Medicare Advantage plans. They use that to project what the cost will be over and above the average Medicare patient over the next 12 months. right? So for patient number 3, they expect to spend $6,000 more than they would on patient number 1 over the next 12 months. And that's one of the reasons why it's really important to make sure that we capture better data in the value-based reimbursement world in order to be successful there, right? We need the right information in order to get that done correctly. I know that a lot of people think, well, that's primary care. I don't need to do that. That's not what I'm after. I just get paid for my CPT codes as long as I've had a diagnosis that makes it medically necessary, right? That's true in the old fee-for-service world. We need better data to succeed in the value-based reimbursement world. We need more accurate diagnoses as the payers start to require them as the ICD-10 grace period expires. We need to be able to accurately show how sick my patients are, right? What's going on with them? How sick are they? What do we expect the cost to be? We need good data in our patient portals. That was one of the things that people struggled with across the country with meaningful use. By the time you finally get your patients to register for the portal and successfully sign in, they get there and the data looks incomplete, right? Because people weren't putting all of the diagnoses in the problem list. And the problem list is what was feeding the patient portal, right? We want to make sure that we're putting that in there so our patients realize we understand what's happening with them. We want to make sure that for our risk measure, our risk adjustment under cost and quality measures and NEPs, we want to make sure that those targets are set correctly, because we're going to be measured in how we do relative to our peers. You can't do well in your outcomes, you can't do well on your cost measures if you don't have risk adjustment taken into effect correctly. Medicare is trying to publish this information on cost, on quality. Nobody wants to be seen as high cost and low quality relative to their peers. There are already several places, ProPublica Surgeon Scorecard being one of them, that uses risk adjustment for surgical outcomes that is published and available to patients. You want to be sure that you're staying on top of this, right, that that's being done correctly, because that has an impact, obviously, to your practice. Commercial payers. Right now, about 18% of the practices across the country have risk-adjusted plans with commercial payers. We expect that will continue over the next 3 to 4 years. And commercial payers are using these HCC methodology for risk adjustment under those plans as well. The last piece that I would mention on this is when you're renegotiating a plan with one of the commercial payers, right, they know what that patient population looks like very, very well. You need to know that as well to level the playing field so there's not asymmetrical information there at the negotiating table. And what that means is, let's say that your practice does 200 total knees a year for Blue Cross patients. Then Blue Cross comes to you at contract renewal time and says, we think we need a discount based on this volume. Wouldn't it be great to be able to say, hold on, time out. Your patients have HCC risk scores, risk factors that are 7% higher than United, that are 10% higher than Aetna. And what that means is your patients are sicker. They're the ones that are most likely to have a post-surgical complication. They're the ones that are going to require additional time and energy. If anything, we should be charging you a premium, not a discount. In the value-based world, that needs to be my thought process, and that's why it's important to have better data. But we've got to be able to capture that without turning our doctors into data entry machines. Right? That's why we want to be able to do it faster than we do today. Think about what that looks like, what it's looked like over the meaningful use era. Our patients don't need doctors entering information into the computer. That's not the purpose, right? And SRS and White Plume have both gone to great lengths to try to make this as fast as possible. Because doctors being data entry employees are not good for patients, and it's not good for doctors, right? There were significant costs to the industry for the meaningful use legislation that came out of Congress, right? Where we were, the industry was hamstrung. EHR vendors had to develop to meaningful use requirements, not to what customers demanded, right? That was true across the industry. And the change to MIPS gives us a lot more flexibility and control Let's take some of that back, right? Let's take some of that back. Don't keep doing things the way you've always done them if there's a better way to do it. There's a 2015 study from the Journal of Participatory Medicine that was really asking about what do patients want? What do they want from their healthcare providers? And this isn't rocket science. This is what you would expect. They want a doctor who listens, who's caring, compassionate, who explains well. They value the interaction between them and their doctor, right? They want to see the doctor's face, not the back of his head. That's what patients want, and that's what doctors want too. Doctors are burned out on data entry. You see this is a study that was done by the Mayo Clinic and the AMA, that they're burned out. You look at the physician burnout rate by specialty, 2011 compared to 2014. 2011's in purple, 2014's in pink. You can see every single specialty is higher, right? Meaningful use has significant cost in that regard. Let's take that flexibility that we have under MIPS and get some of that back, right? Again, don't have time to jump through all the details of MIPS today, but with the transition year that's afforded to us in 2017, very, very easy to avoid a negative adjustment. Every SRS practice should be able to do that, just in the ACI category if you wanted to do that, or if you wanted to submit one quality measure, you know, one clinical practice improvement activity, you can avoid the negative adjustment. A lot of the things that people didn't like about the meaningful use PQRS value-based modifier have gone away. You know, some of the things that were particularly difficult. You know, you now can get partial credit. You can choose which measures you want to do, which ones you don't. Let's take advantage of some of that flexibility, right? And that's why we've done this integration with SRS, so that you can capture better data, so that you can do it faster than today, so that you can capture the data one time and route it to where it needs to go from both a clinical and financial perspective. All right, so hopefully that gives you a little bit of background, a little bit of color commentary of why we think this is important, why we're doing what we've done, and where we hope to go with this. So again, remember the workflow is I can capture the data on the electronic superbill. As soon as I hit save, or save and close, or save and complete, it will send that data both to SRS and will be available to be batched in ExcelisSmart. Now, if there's something that I change, I need to delete a diagnosis, I need to update a diagnosis, I add one later, that will flow across the interface as well. Okay, so let me show you a bit more how that works. And I'll go through a little bit longer demo, show you how some of our practices that have risk-adjusted contracts already are trying to capture some of these other HCC comorbidities. All right, so remember the patient that I've been working with here is Emily Plume, right? And when we first did her encounter, what we were doing was we had the bilateral osteoarthritis of the knee, right? And we also had the lower back pain. She mentioned that one last thing as I was on my way out the door, and we captured the office visit as well. So what I'm going to do is I'm going to pull her electronic superbill back up so that we can take a look at it and show you how I might delete a diagnosis code, how I might change an office visit code so that I can go back through and do that as well. So hold on, let me pull her ticket back up. I already completed it, so I'm going to pull it back up for us. Okay. Oh, you can't see that. Hold on. Yeah, you can. All right, so I'm back to Emily Plume's ticket. On the rank and link screen, I see a summary of everything that was done. If I delete a diagnosis like lower back pain here, right, and I hit save, I'm not going to close it. But when I come back into her encounter in SRS and hit refresh, you'll see that lower back pain goes away. Right now I've got a level 3 office visit. If I need to change that to a level 4 office visit, for example, when I come back into her ticket, I can make that change from a level 3 to a level 4. Hit save, and what you'll see is that information will get updated over here as well. Change from a level 3 to a level 4. So all of that's happening in real time. So if I add a diagnosis, for example, she mentioned something else that I need to capture, right? I come in, I add a diagnosis back of plantar fasciitis, for example. and I hit save, come in back into SRS and hit refresh, you'll see that adds into the problem list as well. If I were to go into the diagnosis app in SRS and I've got a problem that is a chronic condition that I've seen multiple times, it will add that underneath the diagnosis activity so that we're not having a cluttered problem list within the diagnosis app in SRS. That was some of the integration work that went back and forth between our teams in order to make sure that this is successful for all of you. And we're really excited to show it to you today, to get your feedback, and more importantly, to get people up and using it as soon as possible. So let me do this. I'm going to start this encounter over again. Right? So I've got a blank slate here on Emily Plume. I'll go ahead and hit save and come refresh SRS so that you'll see all of that information disappears from my screen in SRS. When I come back into Emily Plume, let's say that I'm going to go through and do that same encounter, but now I'm paying attention to some of my comorbidities, right? Now I want to capture better data, and I want to see how fast I can do that. Let me show you some ideas that some of our clients have had. If I've got a level 4 office visit, and I flip over to the back side of the diagnosis, and I've got that bilateral osteoarthritis of the knee, I can do that with one click. It's very easy to capture that. But they also had a section for comorbidities. They took the most commonly used HCC codes, right, that show how sick my patients are, and included them here in this pop-up to try to make it easy for my providers to say, yes, they have morbid obesity, yes, they have hypertension, and yes, they have type 2 diabetes without complications, right? That makes it very easy for me to go boom, 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 capture that data, and when I hit complete, right, I've got all of those HCC comorbidities captured, and I hit refresh, I've got all of that popping in, populating SRS. Obviously, that'll populate your patient portal as well. I've got all of that data captured in a very, very easy way where I did it one time. It'll put it in my clinical record. It'll send it to my practice management system for the financial perspective, and I'm well positioned to be successful in the value-based reimbursement world with both faster data capture and better data quality. Right? That's what we think is really cool, and I'm proud of the work that our team has done. I'm proud of the work that SRS has done to make that possible. I know a lot of you, I need to be proud of a lot of you as well. I know a lot of you have been asking for this and advocating for this, and we're grateful for that as well. Okay, I'm going to do one more thing, and then I'll try to answer as many questions as I can. Just a quick reminder of what we wanted to say today. It's helpful to say this again. I wanted to show you the demo. I wanted to talk about better data. We know that we're going to need that in the value-based world. A lot of that is about cost. A lot of that is about quality. And if you want to measure cost and quality, it has to be risk adjusted. The government's preferred method of risk adjustment is HCC data, and that relies heavily on accurately coding comorbidities, right? If you need additional information on that, if you want help in walking through that, if you want to look at some of the analysis of how you may be doing on that today, talk with your client account executive. We've got some tools that can help you with that. We've got some webinar content that'll help you get up to speed on that. We are happy to help in that world. We also want to help you do that faster than today. And that means getting down to as few clicks as possible so that we can capture the data one time and send it everywhere that it needs to go. I hope that helps give you some ideas as far as how we have some other clients that are doing that to accurately capture these HCC comorbidities. But thank you again for your time today. We have recorded the webinar, so if you want to share that with colleagues, or if you've got some other SRS clients that are not White Plume clients and you'd like to share that with them, we'd love that too. But let me turn it over to Shelley and see what kind of questions we have that might be helpful for the whole group.